Okay, well, why don't we get started? We have, I think, really in store for a great treat today. However, before we do that, there's the usual housekeeping announcement. Actually, I should have fun here. She's not So, when everyone to sign in, also if you would RSVP to future sessions, that would help us get prepared. For the online participants, please keep your mic muted. Asking questions. Use the chat feature in Blue Jeans if you have technical questions. So the next session, cognitive assessment of aging conditions. And then we follow by the next one will be February 5th. That's improving assistive reproductive technology for identification. Our schedule is on the ACCEL website, and presentations are available on the website. So it's my great pleasure today to introduce Stephen Stanhope. Stephen is the Associate Deputy Provost for Research and Scholarship at the University of Delaware. He's also a full professor of actually several professors at the University of Delaware, including mechanical engineering and biomedical engineering department. He has a really extensive CV. In fact, I was printing it out to look it over. Printer ran out of paper.
I know budgets are tough there.
So I only got part of it. But anyway, he has a very extensive publication background. Primarily the way that was here, Dr. Stanhope, is through the BADER Consortium. And some years ago, Dr. Stanhope approached us, Dr. Weintraub, and the C-Corps team about being the biostatistical core for the BADER Consortium. And so that's how we met him, and have worked with him now for several years. The BADER Consortium is funded by the Department of Defense, and basically the research that we're involved in and that we provide the statistical help for relates mostly to wounded warriors amputees in Afghanistan and Iraq over the past few years. So I think that we're in for a great treat. He's going to talk to us today about what can be done about the cost of chronic diseases and conditions, which I think will generate discussion. So without further ado, thank you, Paul.
Well, I'm truly delighted to be here because I get to take off several of the hats that I normally have to wear on a day-to-day basis and share with you some things that have been real interests and passions of mine over the years. For 22 years, I was a senior scientist at the National Institutes of Health. And if there's anything I wanted to be known for, it was a problem solver. And during my last 7 to 10 years there, I directed the intramural rehabilitation research program at NIH called Physical Disabilities Branch. And got to work with some really outstanding scientists from all over the world and need a little bit of background of information. But before I say anything else, I want to just make sure that no one's allowed to go back and get seconds, because it's my understanding that the governor's been in touch with Janice Nevin, and that we're all to basically defend in place with the big snowstorm, so we're going to be here for the next 2 or 3 days, taking care of the state and all the casualties and things like that. I'm kidding, of course. Well, I wrote my title here, what can be done about the cost of chronic health disease and conditions, wondering how many people would read this as what can be done, or what can be done. And so I want to share with you some ideas on what can be done about the cost of chronic diseases and conditions and such, and share with you some of the experience that I've had. And what I'm going to do is kind of summarize it into just kind of a few brief concepts and ideas. what we found out over the years and how we're currently using it with the Department of Defense and with warriors and the general concepts and things. Hopefully it'll be very thought-provoking. And that's the whole idea. And I'm doing my best to leave 15 or 20 minutes at the end of the presentation so we can really get into some discussion and challenges and those types of things. And with that, let's get off and let's get going. So, if you look at the percent of the U.S. population that's over the age of 65, it's just growing like gangbusters. Okay? And a lot of the data that I'm going to be showing you, some of it might be 5, 6, 7 years of age. I've built some of these presentations over the years, and I'll update some of the statistics. And if you look at the total Medicaid spending, it's just skyrocketing. Chronic diseases account for more than 83% of the $1.4 trillion spent on healthcare in the U.S. annually. The latest statistic is that 86% and it continues to rise. These chronic health conditions, for the most part, are preventable. Exercise, diet, exercise, and behavior. Now, if you reduce smoking, cut out smoking, especially if you reduce smoking and consumption of alcohol at the same time, things like that, because we know alcohol exacerbates dramatically the carcinogenic effects of smoking. So it's behavior, right? So if you get diet right, you exercise, and behavior, we can dramatically control these. So a lot of them are linked back to behavior. In 2002, the elderly, the 65 and older, made up 13% of the U.S. population, but accounted for 36% of the total healthcare costs. Delaware is rapidly becoming one of the nation's oldest states. This is actually one of the reasons why I decided to come to the University of Delaware when I retired in 2007, because of the opportunities here in Delaware. And this is some of the things I want to share with you, some opportunities that you're in remarkable positions to start to maneuver around. Between 1995 and 2000, approximately 25 retirees, 1,000 residents aged 65 and older moved to Delaware. And Delaware is currently ranked the 16th oldest state in the nation. By 2030, Delaware will be projected to be 9th in the station. How many of you are aware of that? Okay. Nearly half, 41.5% of Delawareans above the age of 65 are reported to have a disability. There's a tsunami on its way. This statistic jumps to 67.5% of Delawareans above the age of 85. Okay, so what can be done about the cost of chronic diseases and conditions when you're facing this type of scenario? Well, Delaware is not the only place that has had to deal with these types of scenarios. When I was at NIH, we were contacted by the Italian government. And Italy is one of the oldest nations on Earth, and Italy tracks its healthcare costs very, very carefully. And one of the biggest differences between the Italian system and the U.S. is certainly it's a state-run and mandated system. So they not only track the cost of healthcare, but they also pay for the healthcare and hire the professionals that deliver the healthcare. Okay, so it's quite different from what we have here in the United States, which is primarily a for-profit healthcare system here. And there are third-party payers and such. They're also for-profit, except for the funds to assist individuals. Well, Italy is also one of the oldest countries in the world. In fact, they have extraordinarily liberal immigration laws in Italy now because they don't have enough young people to take care of the older people and do the work and just be citizens. It's very, very, very unusual. Well, if you look at the Tuscan region of Italy, it's particularly true in this particular region. Italy is broken up into these different healthcare regions. LC 10, 11, et cetera, as you go along here. And if you look at the aging pattern in Italy, this is what they call their aging atomic bomb. And so you can see the broadest component of the graph here is the part that has the most number of people. And as you go through the projections in Italy, you can see how that, of course, is moving up. And if you look at the size of the base, it's getting smaller and smaller. Because I believe their latest birth rate was 0.7 or 0.8 children per family or something like that. So they have a remarkably low birth rate there as well. Okay? So we signed an agreement with the Italian government back in 2003 when I was at NIH. And it was to collaborate on studies associated with rehabilitation research. That's what we called it, but it really was in terms of healthcare costs. Okay, but we did it through the Rehabilitation Institute, and you'll start to see why. And the primary project in the collaboration was obtaining optimal functional recovery and efficient managed care for the chronic stroke population. So we used that as an initial population. In fact, that's what we called it. But to be honest with you, we actually started with flex posture and osteoporosis. We had to do that for political reasons, which we might be able to chat about a little bit as we go through here. So if you look at LC 10, this Tuscan region, the really interesting thing about Italy, which is not so different here in Delaware, with the Delaware Health Information Network and such, and you look at the healthcare statistics and all, but in Italy, at just past 5 o'clock every day, computers chug away and out come reports, so you know precisely how much they spent on medications across the country, across the region, physician visits, nursing charges, everything comes pouring out of their database. It is all computerized across the entire country. So they know it region by region, and they know patients who are crossing over regional borders for care. It all comes pouring out of their system every day. It's quite remarkable. We have those capabilities here. They know that there were approximately 2,100 new stroke survivors annually in this particular region. So we started out by mapping the stroke survivors and saying, what's happening to them? Where are they going? And so here you can see a nice little map. You say, for every 100 strokes, there were 19 deaths, 81 survivors, 8 were had recurrent strokes, 73, it was the first. 8 out of the 73 was severely disabled, 65 not severely disabled before the stroke. And then you get down further and you say 15 recovered after the stroke entirely, normal levels. 50 were disabled after the stroke. Okay, so we can start tracking this. In fact, we were tracking them on a day-by-day basis in the Florence region, which is part of the healthcare region. You may or may not have heard of attempts, and you may do this here at Christianity. I'll be interested to know this, the extent with which you actually do mapping of patient care activities in the process. You know, so this is basically the map for someone that has a stroke in Italy. And I won't go through this in great detail, but you can see how you've had your stroke up on the top left-hand side, and you come down, and there are different types of milestones that are discovered in here. You know, is it the first one? What's the level of your disability? Do you have dementia? Any cognitive, aspects? If so, you go off on certain paths. If you look at all the way on the right-hand side here, you can see this is all basically chronic stroke conditions. So there are a number of pathways that you can end up having then chronic stroke conditions. And we started monitoring those chronic stroke conditions. In Italy, what we put in place as part of the research project, that the federal government in Italy mandated that every healthcare provider in healthcare region 10, whenever they had a contact with a patient that on their chart said that they were one of the stroke survivors, they must record their functional level. So it had measures of function, get up and go, 6-minute walk test, and things like that. So we could then put them on a blip to say what's their functional level. And then we could start to link their functional level back to healthcare costs. And it's quite fascinating. So basically, here's a graph of similar what it looks like. So this is state-run healthcare. So you've had your stroke, you get your initial bolus of rehabilitation. You see that on the far left-hand side here, and you boost your functional level up to some level. They discharge you, you go out into society, you go back home and you sit around, and your functional level starts to decay down until you get to the point where you say, I need to go back and see my physical therapist. It's been 8 weeks and I'm having a hard time breathing, such and such. I'm gaining some weight. You go back, you get a little boost again. You go back, you start decaying down, and your function just keeps spiraling and decaying down. And the healthcare system keeps trying to provide services to try to pop you back up, boost you back up. And the cost, while function is spiraling down, the cost is starting to spiral out of control. Because now we've got hypertension, diabetes, overweight, you name it, congestive heart failure, all these healthcare, now we've got chronic health conditions. So secondary to the fact that they have a stroke initially. Okay? So, what we'd like to do is to say, you've had an incident, you're in the hospital, get your acute care, get your bolus of rehab and such, get up to the plateau and stay there, right? right? And then we can all have abdominal aorta ruptures when we're 90 years of age, and within seconds we have this warm feeling, we pass away, and everything's fine, right? It's the simplest and easiest way to go, right? You know, what we've learned is that you can use different types of services to boost a person's capacity to function. And you can keep putting those services in and boosting their ability to function. But you know, for the most part, this is what we have. And every time you put those services in, you realize that you've got a physical therapist, nursing staff, and everybody working one-on-one. And this population, this chronic condition, continues to grow and grow at 2,100 per year. It is not feasible to provide that level of service to keep people boosted, so it doesn't occur. And at most, at that point in time in Italy, we had individuals that would cycle back and they'd say, we'll put you on the waiting list for physical therapy, you know, because we understand you need a little boost, you know, you need some help here and those types of things. The waiting lists get longer and longer. Okay? This sedentary lifestyle builds up more and more, and so the whole idea was that, you know, is there some way we could actually shift kind of the burden of this onto the community and have community-based activity programs, and how would we actually do that? So shift the burden of care or functional establishment and maintenance out to the community. Okay? Two concepts to keep in mind here. One is initial bolus and treatment, focused on helping the person as much as possible get to the highest level of function, and then somehow being able to maintain it. Okay, so the goals for the community-based, what we call adapted physical activity programs. And if you see a P in there, it's the P's from the Italian component. Okay, so in Italian, the P would be, I should say, sometimes you'll see an F, I should say. So you'll see APA, AFA sometimes throughout this, I'm sorry, to make the confusion, but you see that switching back and forth sometimes. So the whole idea is to improve function and functional use of compensatory strategies and such to increase endurance, muscle force, joint flexibility, and thereafter functional status, and thereafter social participation. Okay. So the hypothesis that we came up with was, you know, you've had your incident and you end up with an impairment. So you might have weakness, it leads to functional limitations. Now you have poor gait, slower gait. You have poor balance and such. That leads to disability. Now you can't do a number of things. You can't necessarily go shopping for yourself. You can't necessarily be at work, do those types of things. So what do? You have a sedentary lifestyle. The sedentary lifestyle leads to chronic health conditions in terms of obesity, high blood pressure. See the cycle? And it keeps building on itself. And the more the population with chronic health conditions grows, then the less is the capacity of the healthcare system to break the cycle. And it keeps growing in itself, and suddenly you've got, like here in the United States, 86% of the healthcare cost, which is about $1.2 trillion a year, is the current estimate, is due to the cycles. So, you know, the whole concept is that can you get in here and can you really work with activities that help with muscle strength, you know, flexibility, with balance, with activity, and can you do it in a kind of an environment where it's kind of social and it's interactive and such, and can you do this all outside the healthcare system? So the Adapted Physical Activities Program, or APA, is really a physical activity program that's adapted to specific chronic alterations of health status for the secondary or tertiary prevention of disability. And if you're pretty good with Italian, you can Google this online. It'll all pop up and you'll see it all in Italian and stuff, with maps and things like that. Okay, so really try to do physical activity programs within this paradigm. First, get them to the level, then maintain it outside the system. So we started with stage one was a hospital-based group sessions because we had to demonstrate through demonstration projects that we could come up with different strategies for being able to do this. We also had to start in the hospital because the physical therapy union in Italy was fighting the general concept. How dare you have people give physical therapy services to people in the community? They're not physical therapists, they can't do that. So there was really a war that was waged with regards to what are people in the community allowed to do in terms of helping people do exercises. So it actually started in the hospital, and it was with physical therapists going through the intervention, and then with future hospital paradigms, we started to have volunteers helping out, and then eventually transitioned it to the community. But it took about 2 to 3 years to do that. It was about a 10, 12-year effort this went through. So we had basically 2 groups, a study group and a control group that went through, and I won't go into great details on here, but basically the adaptive physical activity group 2 times per week were coming into the gymnasium at the hospital, and they were going through different exercises and such, and the other group basically were sent home on their own. This is actually a set of instructions for people, but it was actually for the flex posture osteoporosis group. I couldn't find in my records what the instructions were for the people for chronic stroke. And they're actually online now, lists and manuals for Parkinson's disease, you name it. They now have APA programs for all these different types of conditions. So they're basically condition. They're not disease specific. They're condition impairment specific. Here to get a person to a functional level, not treat the disease, but get them to a functional level. And so the results are: green is the exercise group on the left, and going up from the first baseline to the 6-month study, you can see they go up in the control group. There's the beginning of our spiraling going down. And then you can see this in terms of 6-minute walk tests. So the green group is going up, in both cases, and the red group is the control group. You can see the function spiraling down. So these are actually the data we use to then go back to the healthcare authority and say, we want to ramp up to the next level and start working on implementing this. And you can see Berg balance scales, same types of things. Better balance, and all those kinds of things. And short physical performance, battery, nice increases and things like that. So you can see how you can not only maintain that plateau, but you can actually help boost people up by these types of exercise and social intervention. Quick story, I know I don't have all day, but I'd love to have you all day, but a quick story about this. On one of the occasions when I went back to see the status of the studies, they were also having a subject cohort meeting. And you think, what? They had 250 individuals who were post-stroke at the meeting to talk about the status of the studies and the activities and such. And they asked me to address the crowd. I did a little bit, and at the end of the meeting and everything, all the ladies who came brought all their baked Italian goods and things, and so everybody had to eat all the goods. And then they got so excited that they arranged a weekend trip to the coast. And so within about 30 minutes' time, 250 people had arranged the date of the trip to the coast, the buses, and everything. And what you don't know is that, well, you may not know, but in Florence, Italy, there is a volunteer program that is hundreds and hundreds and hundreds of years old. As a young adult growing up, you volunteer time to people to help them. You transport them, you get food for them, you help people. And every time you do that, you bank hours. And by the time you need help, you have thousands of hours banked and other people help you. It's been going on for hundreds and hundreds of years. It's a remarkable thing. So volunteers stepped in and got buses and the whole bit and had a great time. I don't know what that does to the statistic, Paul. But it's remarkable. Okay, so the next stage 2 on this, when we demonstrated the effect of this, was transition the program to a community-based model. Establish the adaptive physical activity principles and establish and support the community-based network. So the principles were things like it's continuous throughout the year, it's specific for given clinical condition, it's not provided by local healthcare authority, it's provided by volunteers. Okay? It's coordinated by the local healthcare authority to make the calls. Local healthcare authority trains volunteers on those types of things, but it's done by volunteers. It's activated by general practitioners, a specialist. So you go to see your doctor, and it's time for you to get to the APA program. They refer you to the programs, and they take notice of whether or not you're there. They take attendance at the programs, and if you're not there, your cohorts in your group contact you and say you're supposed to be here. Get there. They come and they pick you up. The volunteers go and get you there. And if you're still not going there, the next time you see your general practitioner, they say you have not been going to your adaptive physical activity. What's wrong? And they make it work. And so it's really supported by the local healthcare authority to pay the bills in the end. So who pays the cost? Each person who participates pays 1.9 euros per session. to participate in it. And that's about as much as a Bosquito and a cup of cappuccino. Uno cappuccino and a Bosquito, and you're all set. And each time you go, typically 3 times a week that you go. Okay. Annually now, with these programs that are done by volunteers and communities, and you'll notice in this slide, I'm going to step away from the mic for a second, but you notice in this slide, you'll see groups of individuals. Those are the various teams. Those are the various teams in their groups with their volunteer. And annually, they all get together for AFA Day, Adaptive Physical Activity Day in Italy. Okay? When I was last in touch with this program, it was remarkable because it had gone nationwide and such. However, we had 700 in 2008. So this is 5 years after starting the concept. In 2008, we had 709 courses going on. And that's not individual sessions, but 709 times that people are going to a group 3 times a week. At 316 locations with over 12,000 participants. Okay. Subsequently, it's currently a national program. We were able to track and see right off the bat there was a small area named San Maniato, and San Maniato was losing 2 to 3 million euros a year because their chronic stroke survivors were going to Florence in a different healthcare region to get care, and the Florence region would charge the San Maniato region. So they saw this outpouring of money because another region was taking care of their citizens. It stopped that. It dramatically reduced the cost of the chronic health care conditions with people cycling into the program after the Really simple, really difficult to implement. And some people might say impossible to implement in the United States. Open for debate and discussion. Okay? Some of the younger folks in the room might see other healthcare systems there and might see more of a push towards this type of activity in the future. Because when you think of 86% of all healthcare costs, $1.2 trillion, and how we're going to affect it, I'm here to present some concepts in terms of how we've been able to do this in some other countries that are highly ranked in terms of their healthcare system. Okay? And so this is just kind of number of locations as they were mapped out. Again, all coordinated by the local healthcare authorities and reported centrally. So currently a national program. You can imagine currently the difficulty if you say, gee, we want to take everybody who's had an aortic valve replacement or procedure or something. Let's get together and have an annual meeting and see how you're doing with something or other. The capacity to track individuals and their functional status exists, especially here in Delaware. The capacity to put in demonstration programs exists here in Delaware. Remarkably difficult to do something of this nature if we were in Maryland or Pennsylvania and you look at the disparate healthcare providers and everybody battling for the dollar and those types of things. But you can actually, here in the state of Delaware, we have the capacity to steer resources and activities in ways that can be really profound. And the federal government's very interested in seeing programs that can do this type of steering. So some fundamental concepts, number one, initially reach the recovery plateau level. You've got to do it. Great healthcare providers, really attuned to that immediate healthcare need, the acute, and to a certain extent subacute stage to make sure you get the functional level up there. So health status and functional level high, and then 2, to maintain the functional capacity outside of the healthcare system, and initiate the program through research activities. More groups think that they could initiate programs of this nature by using the cost, and the burden of the cost is on the healthcare system. It's already burdened with cost. We did it with grants in Italy. We did it with funds that we applied for. That's why we staged at the hospital with a small grant, got some money back, got some additional money through the, basically the Italian NIH is what it was funded. Sure. And to bring it in and then do it in partnership with healthcare authorities, do it in partnership with hospitals, do it in partnership, and then move along until you get it to the stage where you have enough information together and it's readily adaptable. and put in place. Great state. Delaware is in a perfect position for demonstration projects of this nature. Okay, so let's use the same concept. Let's help the Department of Defense with the healthcare costs and recovery levels of wounded warriors with extremity injuries. You can imagine my response when I saw DOD puts out a call and says, anybody have any ideas for creating a consortium that's going to help Department of Defense do research that's going to improve function of wounded warriors, extremity war injuries and such, whether it's limb salvage procedures or amputation and such. So I'm thinking, gee, I wonder how we could approach that. So a colleague of mine, Colonel Thickey, who's actually retired now down at Johns Hopkins, and they're actively recruiting patients from Delaware down to Maryland at Hopkins because they're capitated what they can make down at Hopkins. So I just found that out recently. Mechanism of injury, if you look at the past series of wars that we've had, and I didn't put the worst photos in here because I have photos of quad amputees. And I have to be honest with you, the first time I saw them, I studied anatomy, and I just thought, oh, that person's lost their life. And then to see that person in our research studies and see individuals in our research studies and the level of function has been truly remarkable. 14% gunshot wounds, you can see fragmentation and blasts are a large percentage of it in the IEDs and such historically. If you look at the cost of the conflict here, you can look at the concept, and these are older numbers, and I'll give you some updates on these. Currently, there's about just over 66,000 individuals have been injured in the various conflicts that we've had overseas, and a vast majority of those injuries, the extremities are involved. So you can see that back in 2011, there were 42,000 battle injuries, 50% were evacuated. 82% of battle injuries have an extremity injury, an average of 2.3 per injured soldier. So the extremities, and it's partly because of the types of Kevlar protection and such that the soldiers are currently wearing. An interesting thing which is really the part that I highlighted here is that this accounts for 65% of the disabilities. These extremity injuries are cause 65% of the disability claims and such, which cost the Department of Defense and the VA $1.1 billion on an annual basis. It's because of the disabilities. So you can imagine, you've lost both lower extremities. What's your functional level? How high is the plateau that we can push you up to? Okay, and then what could we do potentially downstream? Well, the focus of this consortium is really, and this is actually the call. So this opportunity came out of the congressionally directed medical research programs that comes directly from Congress, and it was to establish a strong infrastructure for continuing clinical studies on combat-related musculoskeletal injuries and products that result in changes to or validation of current clinical practice that lead to better outcomes for our injured warriors. Better outcomes. Let's help them get there. So the concept was let's push this plateau up. We put out a proposal for the BADER Consortium, which we'll forever be thankful for Christiana Care's assistance with biostatistics support. This team here is remarkable. What they've done for the BADER Consortium is just incredible. So all of our proposals that we're sending in through various programs and such, and I just have to say, we've submitted 12 proposals for funding outside of the BADER Consortium. This is a side comment. 7 of them have been funded, 2 are waiting for funding. If you look at the rate at which we're getting funding, coming, and they go through the biostatistics score and everything is really quite remarkable. We're not in the single digits. We're at 85% funding rate for the proposals coming out of the consortium, which is really remarkable. I want to just officially thank the biostatistics group for what they do. Is remarkable. So the mission of this consortium is to help establish sustainable world-class programs in orthopedic rehabilitation research at Department of Defense military treatment facilities and U.S. Department of Veterans Affairs sites that results in evidence-based orthopedic rehabilitation care. However, the vision is that wounded warriors and civilians with limb loss and limb difference will routinely benefit from significant advancements to obtain optimal functional clinical outcomes and fully re-engage life and work activities. Do you see the prosthetics? And I cut to the chase. Over 300 individuals with lower extremity limb loss are now back to work full-time through the systems. And we have, I believe the number is 74 individuals with limb loss are back full-time with their units in the combat zone. Okay. So what we've built is a network across North America. These are all different sites for BADER Consortium affiliates and the experts that we have. And we built this whole structure to be able to basically support from the most advanced technology all the way through physical therapists and data, people to help collect data and those types of things. All of it geared towards studies to get optimal levels of function. We've got a whole host of collaborators. And one of my comments that I want to share with all this, if we can do this across North America, we can certainly do this throughout Delaware. This is a $20 million award. And we just submitted this past December for an $18 million renewal. Okay? We've got 8 projects that we're funding. We have 42 other projects that are supported via other mechanisms that we're currently supporting across this. And what I want to do is just give you kind of a snapshot of some of the things that we're doing. One of the facilities that's been built and the capabilities put in place at the military treatment facilities is a virtual environment. And so this is a treadmill, overhead harness and a whole bit, where it's a 3D environment that's projected in front of the individual. And the treadmill changes its attitude, its speed and all. And so you can immerse a person in a 3D environment. And so we currently immerse amputees in a 3D environment and challenge them. So, I mean, just stumbles and falls and all kinds of things happening to them. And they dramatically improve their ability to maintain balance and function in that environment that we've been able to demonstrate. We've built some technologies so we can monitor the types of forces that are occurring, because typically the amputated limbs forces end up being different from the natural side of the body, if in fact you're unilateral. And if you're bilateral, they can be different from normal. And so we can actually now in real time measure the forces, and we can provide biofeedback to a person as they're walking, running, doing different activities, so they can learn to balance the forces, and we hope reduce the incidence of osteoarthritis and low back pain and things like that in the future. This techniques are now used at Walter Reed in the physical therapy clinic, and we expect they'll be moving out to San Diego Naval Medical Station, they're called BAMC, or the Stanhope Intrepid, Houston, Texas, and a number of the other sites. We're looking at outcomes from trauma patients, so we're benchmarking the current levels so we can demonstrate the increased levels that we can get in the future and such. We've got a quality of life toolbox, because we're looking at higher and higher levels of function, and we don't have any outcome measures. In a rehabilitation context, do you typically ask your amputee, did you win the gold medal in the Olympics? If you remember Pistorius doing that, and we now have technologies that we believe would actually give the amputee a significant advantage and likely be able to do that, but they're prohibited from being used. We're going to change most of this. We've got robotic ankle foot systems now that we're using. So basically, they replicate the plantar flexors and the dorsiflexors, and they are adaptive in nature. So we're studying those to see if we take somebody who's a K2 and a K3 ambulator, because historically in the civilian population, you say, oh, you're a K2 ambulator, you don't walk very well. If we give you a robotic ankle foot system, and we've got some people here in Delaware using them bilaterally, can we actually get you to be a K3 or a K4, a high-functioning individual? And therefore, your level of function activity is dramatically higher based on that technology and such. So we're studying that, and it seems to be very effective. We're tracking, I think our number here is, this is we've got 1,300 subjects that we're currently engaging across North America. And so we can basically maximize the outpatient rehabilitation effectiveness to get that plateau as high as possible. So we're measuring it, and we're working across all these centers to maximize that and keep pushing the envelope up. We've got a study that we're working with a number of the manufacturers to find out precisely how the device is designed, especially when you've got people carrying 90-pound rucksacks and things like that. When you're going to be in construction, you're an 18, 22-year-old individual. I mean, the prime of your life, you're going to work. You're going to work hard. Well, can devices keep up with that? So we're studying that in the protocol. And then one of the ones that is near and dear to my heart, because I've got a number of techniques associated with this area, is the prosthetic leg prescription. And it is how do you maximize the length and the stiffness the springiness of the prosthetic limb, its moments of inertia and things like that to optimize a person's function, actually give them a significant advantage. Okay? Now I'm going to click a button here, and when you think about rehabilitation, and you think of someone who, remember I mentioned someone who had a quad amputation, so they've lost arms and legs. And what level of function do you think they should have? That's the rehabilitation paradigm. It's what they're calling the new normal. There was just an AMSIS meeting last December. And AMSIS, which is the International Society for Government Healthcare Providers, and their theme of the meeting was the new normal. And we had NIH, DARPA, TATRIC, DOD, VA, all there talking about what's the new normal, what are we shooting for, what are we going for, okay? I don't think he sees any limits. There's another quad amputee that lives up in Maine, and he drives 9 hours one way to get down to Walter Reed to get his prosthetics adjusted. Things like that. No limits. Okay, so highest possible level of function. Back to work, fully engaged in society. Okay, that's the concept. Why? It's right for the person. Also, we will be tracking to see the extent to which it dramatically reduces the costs downstream healthcare. Is he going to try to stay slim and fit? And you get that sense, as opposed to the home. Okay? The Defense Health Board oversees and reports on the status of Defense Health Agency activities. And in 2003, they started doing an investigation on basically programs associated with amputee care. And I had the good fortune of being able to testify in front of them a little bit. In their report, the BADER Consortium was the only entity, really, that they mentioned that is doing consortium activities. And it said, basically, that the BADER Consortium is central to the ARCs, which are advanced rehabilitation centers across DoD, research capabilities and current efforts. And BADER significantly enhanced and facilitated, and this is the research capabilities of the ARCs. Okay. So with that, I thought that could open up some discussion with regards to this type of an approach for whether or not we can reduce the cost of chronic health conditions, or can we? What do you think?
Better.
We're better. We're better. What do you think? Go ahead. Go right ahead.
So I'm not too familiar with Italy, but I imagine they have a lot of rural areas, and there are a lot of rural areas in Delaware. So how do you see, you mentioned that volunteers would go pick them up if they need to, but I know a lot of the elderly might not be able to travel to a central location. So how would you be able to bridge that gap
Yeah,
here?
great question. In fact, in Italy now they have several mechanisms of doing that. One is telerehabilitation, and that individuals get basically the capacity to participate in the group but from home. So through computer systems and screens and things like that. They also have what they call, if I get this, my colleague there is Francesco Benvenuti, if I can get this term right. It's rehabilitation gazebos. So they go into remote areas and they create small, basically it's almost like a small hut that they set up. And so individuals go and they enter, and they have technologies there so they can participate through tele-rehab technologies and things like that. And so you could have maybe 2 or 3 people there participate in the activities. So they've got all types of things that they're working on currently to be able to do that, as well as the transportation system to give individuals, credits for buses and things like that, and for taxis and all those kinds of things. Because when you look at it and you say, gee, if there's a $5 to $10 cost per visit for this particular person to participate in these activities, and the government knows the cost of the health care if they don't do that within a year or two, you say within a year it's going to cost us $400 or $500, but if we don't do that, within a couple of years it's going to cost us thousands and thousands of dollars. Mm-hmm. Because now we've got to get that person from the rural area to the hospital. We've either got to keep them in a hotel, or they have to be an inpatient to go through their services and such. So And that's one of the interesting things is if you've got a single entity that's responsible for the cost of the care and the provision of the care, then they're able to kind of look at it in a grand scheme and say, ultimately, the cost that I save now, the cost that I put in now, can I save money long term, where we don't have a system like that here in the United States. If you're the insurance company, you say, I'm not going to pay that. There's fine print here, I don't have to pay that. Because the cost downstream hopefully will be somebody else's burden to bear. Okay? In Italy, it's going to be their burden. So you can see where that, the fact that they can project it out and such. So a lot of those types of systems they're putting in place because they realize they're dramatically reducing the cost.
Oh, yeah, it makes sense to just,
In that regard, have they studied cost effectiveness in the program in Italy? You guys studied cost effectiveness in the BADER program?
We haven't done cost. In fact, they've asked us to do that with the renewal. One of the areas that they want us to study is start to look at cost effectiveness. And one of the teams, A.J. Johnson, who's in Stanhope and BAMC, is now tracking all the amputees and such, and individuals, not just amputees, but individuals have limb salvage and extremity injuries and such. So we'll have some idea of costs in the future when they establish.
We have a lot of expertise here, as you're aware, in cost effectiveness analysis.
Those will be wonderful opportunities. Yeah, because that's actually that is a mandate for us to start moving in that direction in terms of the BADER Consortium and these activities.
Wonderful, impressive presentation. Thank you. My question would be for the amputees who are going through this rehabilitation program and become so functional, have you looked at any secondary effect of that program on like PTSD levels, the depression levels?
Great question. Now, we haven't, but I believe there are other groups that are starting to track that information. So the question was really looking at not only the rehab component of it in terms of physical function and such, but post-traumatic stress disorder and things like that. There are a number of potential secondary things. A lot of the secondary conditions are things like low back pain, contralateral knee joint, osteoarthritis that might build up and things like that. But a number of the other things like post-traumatic stress disorder, and the extent with which they're engaged in society work and those types of things, we hope to be implementing in the program.
Well, I'm actually just today I'm organizing a meeting among Dr. Emily Hanstein. She's a senior director of the School of Nursing at the University of Delaware.
Yep.
And her colleague from the University of Pennsylvania Psychiatry Department, Michael Black, and also the SAMHSA individual in Delaware State. They're all experts in mental health and depression. So if you're interested, I'll keep you posted.
Sure.
What comes out of it.
Fantastic.
Yeah.
Wonderful. I have one over here.
Yes. Hi. Thank you for this is really interesting. I had a question about the functional capacity, and especially with the aging population, is there any expectation that they're going to lose some functional capacity just as a result of natural aging? It's not just from whatever their incident, their stroke or whatever.
Sure.
So how is that measured? Is that taken into consideration in the analysis?
In this particular case, we're looking at chronic conditions typically associated with some sort of infarct, and they're not doing it just generally in terms of aging.
Okay.
That's to the best of my knowledge at this point in time. But that's a great question because it really gets at the concept of what's that threshold of function, and what is it? How do we know whether we're above it or below it? Because if you're below it, you want to get above it. And how do we as a society, just with natural aging, help people do that and maintain that as much as possible? So I think it's fundamentally the same concept. And I suspect there are different programs that are doing that. But it's another great opportunity here because Rita Landgraf from the state of Delaware is looking at aging in place. There's a huge effort here in the state of Delaware and such. And so any types of systems that can be put in place that can ultimately keep maintaining higher functional levels, I suspect will be dramatically impactful in terms of cost of healthcare, people's function, social interaction, those types of things. We can't all be down on the ocean walking up and down 2 miles a day along the water, even in the snow. But it would be ideal.
Although that's the plan for
That's the plan for many of us, yeah. Buy early.
So the volunteer program in Italy,
were the volunteers trained to provide these physical therapy services to the patients?
Yes, they're not physical therapy services, they're adaptive physical activities. And so a person could look at it and say, well, can't physical therapists do that? Yeah, but they're trained by the local health authority. So they have instructions, not only instruct, because you don't do it for the person, but basically say, here are the activities that people are supposed to be doing. So there's stations, and people rotate through the stations. And so the person does their own activity. It's being able to basically monitor it and see what they're doing, have the information there for the different activities, take attendance, those kinds of things, and collect your 1.9, roughly €2 per visit.
I'm a little worried about the sustainability of a program which is only based on volunteers. And I'm thinking about that because here, more and more, we have, for example, community health workers, who are trained to go to the community and do blood pressure assessment, all these kind of things, but they are paid people and probably obviously less paid than a physician or a nurse, but that's also a very good opportunity to go to the community and provide some care and try to avoid chronic disease. So
what you're suggesting is to really maintain that volunteer group, you've got to put resources into it. You've got to really make them a community of sorts. You've got to be communicating and such, and that's what they do. Because they realize if they do that, and they're not paying them, but they're really treating them wonderfully and very professionally. And they grow the volunteer, and that's culturally they're just coming up with methodologies to get people engaged, keep them engaged, and realize the extent with which they're impactful. And that's to a great extent why they have these AFA days to bring all the volunteers. They get their T-shirts, they get all this recognition, they get awards and all those kinds of things, and say, look at the amazing things that you're doing. Look at how people are functioning better. Look at the cost of healthcare is coming down. The lines are reduced, the waits for, and so they do it really socially by having people engaged, which is remarkable. But that effort has to go in. And to do that, it has to be demonstrated that there's some downstream savings and value.
Have you looked at issues related to health literacy? I think we end up with a paternalistic healthcare system here because we feel our patients don't understand. And we feel like we're trying, but I don't think we try very hard. We don't really know how to work with people on health literacy. The more you put things out in the community, the more important it is to get people to understand.
Yes. Yeah. In fact, they do an awful lot of education, a tremendous amount of education. I remember this is 8-10 years ago, towards the tail end of this, because they're really looking. They were really ramping up to say
in Italy.
In Italy, yep. In terms of a person's choice, particularly for diet. So they started creating educational sessions in the local communities with regards to, and the poster read, healthy food that tastes good too. That was the translation of the poster and such. And they do their best to educate individuals with regards to health, nutrition, and those types of things. So there were very large efforts there, as far as I was concerned. I don't know. I mean, the opportunities we could have here with regards to just regularly educating children, starting at young ages and things like that. And how long did it take us to finally start to impact, soda machines in schools and types of, can you have fresh fruit and vegetables in schools and things like that? But I suspect we could do that here in Delaware. Just interesting, some thought, food for thought, in terms of how to. One of the take-home messages is that don't be afraid to think of an approach because you think it would cost too much. It's those approaches that end up being highly novel and remarkably impactful that agencies like the National Institutes of Health, that has $32 billion a year to spend on research activities. So people can demonstrate, so regions, states, systems of care can demonstrate new ways of doing things to positively impact the system. We have remarkable capacities to do that here in Delaware. It's truly remarkable what we can do. Yeah, 932,000 citizens in the state.
So what are the capacities? When you say we are the remarkable capacities, which capacity do you see?
You've got a remarkable capacity to track all the health statuses here in the state, to educate the young, to see the impact of that education downstream. You've got a remarkable capacity to measure function. Was it 85% of Delawareans get health care through the Christiana system? What's their function? The number's really large. What's the number in terms of their functional level across different capacities? So when you discharge a person for care or into cardiology or neurology or different areas and things, what's their functional level? What measures would you want to make? And you can get those into the system and start demonstrating what people look like, and then start theorizing if we could give them a bump, what would happen downstream? And that starts with those kinds of thoughts, getting people together and starting to dream of how you could possibly and potentially positively impact the system, and those become proposals. And we're getting really good at those big proposals here in the state. Really good at it. Really good at it. Really good proposals. Really good at it. Start to really leverage these capacities. Thanks for coming today. I enjoyed it.